Hey, I'm Dan Marchalik. I'm a urologist at MedStar Washington Hospital Center and Georgetown University Hospital. And I'm also the medical director for physician well-being for MedStar Health. Today I'll be talking about burnout. In general, burnout for physicians in the United States and actually internationally, but also burnout in urology specifically.
So the first question is, what is burnout?
Yeah, so burnout is defined as a workplace syndrome, and it's recently actually been designated as separate, specific entity, a separate syndrome. But it has to be rooted in occupational hazards. And the way that we define burnout traditionally is the way that it's measured, which is the Marchalik burnout inventory. So we think about burnout as having three components. The first is emotional exhaustion, which is this general feeling of, I can't really do this anymore. The second is depersonalization, which is a feeling of callousness towards your patients, towards your colleagues. And the last is a lack of personal accomplishment, which is the feeling of, even if I wanted to do something about all this, I just don't think it would make any difference. And this is how we traditionally define burnout, but what's more important are the consequences of burnout. So the things that we've kind of started to see over the past 20 years, physician suicide, depression, divorce, increased rates of medical errors, worse outcomes for patients, all of these things we've now seen as being sequelae of burnout and being intimately linked to burnout. So I would think about burnout not as just its definition, which really has to do with the instrument that we use to measure it, but more with what that entire complex of symptoms really represents.
The next question is, why do physicians have a particularly high rate of burnout?
Yeah, that's a very good question. And the truth is we do know that physicians have an atypically high rate of burnout. And we've seen that in a series of large multi-specialty studies. The big ones were done by Tate Shanafelt's group. And it initially looked at the rates of burnout between 2011 and 2014, and then a follow-up for 2017. And basically it compared the general population to physicians specifically. So looking at what are the differences in burnout. And what we see is that physicians burn out at roughly double the rate of the general population. Now, a common thing that people say is like, well, it just has to do with higher education. It's really stressful to go to medical school, and maybe that's what's really adding to it. Well, interestingly, in that same study, the follow-up, they took a look at the difference in burnout for MDs and then and DOs and then non-MD DO types of doctors, so PhDs, JDs. And what they saw is that being an MD or DO type of doctor actually increases your rate of burnout by about 40% on top. So it's not a higher education thing. We know that there's something intrinsic to medicine that's causing these issues.
It seems even within physicians, urologists seem to have a higher rate of burnout than even other specialties. Why do you think that is?
Yeah, it actually does seem to be the case, and I want to preface it by saying we actually don't know much about burnout in urology specifically. Despite consistently coming up as the specialty with the highest rates of burnout, we're actually the most understudied specialty in medicine. We have the least number of studies specifically looking at our own drivers internally. And what we do see is, and we've seen this on multiple multi-specialty trials, including Tate Shanafelt's study that I alluded to earlier, Lottie Derby's study from Mayo on burnout in residence and career regret, even colloquial studies like the Medscape study on depression and burnout in physicians. All of these are placing urology at the very top in terms of burnout rates. As I had said, there's not a lot of data out there on urology specifically. We had conducted a couple of studies on burnout to try to understand this a little bit better. So we recently conducted a national study on burnout in urology trainees, where we looked at both individual and organizational causes for burnout. So we assessed things like, are you spending time with family? Are you doing yoga? Are you meditating? But then also, what are your work hours? What's your access like to mental health services? Do you have mentorship in your program? And what we saw is that institutional factors actually played a really key role. Having a structured mentorship program was protective against burnout. And this is something that we've seen before in other surgery resident studies. But we also saw that having readily accessible access to mental health was a huge predictor of residents not having burnout. Interestingly, I think that access to mental health was actually a surrogate for something bigger because, for example, programs that had easy to access mental health services were also the types of programs that were less likely to violate work hours. Right? So I think there's something there about what we do programmatically in the GME and the types of effects that has on our trainees. And what's interesting is we actually did a follow-up study where we compared burnout causes and sequelae in trainees in the US versus trainees in Europe. And we saw a lot of similarities there. Certainly structured mentorship is something that came up very clearly in both cohorts. But then some things were a little bit different. For example, the number of weekends on call was more of an issue in Europe than it was in the US, and I think that has to do with expectations to some extent, right? Because I think here there is more of an expectation that weekends are times that residents work, and maybe that's less of an expectation there. And so I think this is going to require further inquiry. And I think as a field in general, because of the rates of burnout that we're seeing internally, we really need to start concentrating more and trying to elucidate why specifically that's happening.
Do you think with the information that we have now, there are any ways to reduce burnout in the medical world?
Yeah, absolutely. I mean, of course, this is a huge part of my job as medical director for Wellbeing at MedStar is actually trying to think through these. And I think these interventions, like any other intervention that we would do in medicine, have to be evidence-based interventions. Now, some of these are clear, right? Repeatedly data showing us that having better mentorship makes a difference, right? That not violating work hours makes a really big difference. That having institutional policies like access to mental health and support makes a big difference. But there's other studies that have demonstrated things like community building, programming. For example, a big study done out of Mayo, which was a randomized controlled trial looking at community building lunches. These things can make a difference as well. I think at the end of the day, with increased awareness of burnout and sequelae, the right thing to do is to do something, right? I think just starting to make a change in and of itself is actually going to be an impetus for further change and further improvements. But the other thing we have to do is we have to continue to take this seriously and to measure it. A lot of pilots are successful in burnout, and a lot of pilots are not. And I think that we need to have as rigorous of an approach to this as we would to anything else in medicine. I mean, we need to do these studies. We need to make sure we look carefully at whether our interventions are working. And if they are working, we need to scale them. And if they're not, then we need to move on.
Great. Well, thank you so much for your time. I appreciate you talking to us.
Yeah, it's my pleasure. Thanks so much.